Welcome, everyone. My name is Francine Allen, and I'm a registered dietitian in medical affairs with Nestle Health Science. I'm delighted to introduce today's speaker and assist with the webinar entitled Enteral Nutrition in Pediatric Critical Care, Guidelines and Evidence-Based Management. Amy Henriksen is a registered dietitian, nutritionist, and medical scientific liaison specializing in pediatrics with Nestle Health Science. She earned a Bachelor's of Science in Human Nutrition and Dietetics from the University of Illinois at Chicago in 2001 and her Master's in Public Health from Northwestern University in 2008. Prior to joining the medical affairs team at Nestle in 2009, Amy worked as a pediatric registered dietitian and nutrition department manager at La Rabida Children's Hospital in Chicago for 8 years. At La Rabida, Amy provided nutritional assessment, management, and education of children, adolescents, and their families with medical conditions such as diabetes, obesity, failure to thrive, cerebral palsy, intestinal failure, burns, etc., and other conditions associated with prematurity. Amy has presented lectures to healthcare providers on various topics for over 15 years, including enteral nutrition in pediatric critical care, nutrition for the neurologically impaired child, nutritional management of diabetes in children, and childhood obesity. So welcome, Amy.
Thank you very much, Francine. Hi, everyone. This is Amy, so thank you very much for joining the webinar today. I'm excited to talk to you today about enteral nutrition in pediatric critical care. The objectives of our talk today, we are going to address the challenges and goals of nutrition support in critically ill pediatric patients. We're going to describe the nutritional management of these patients, discuss evidence in support of early enteral feeding and the use of feeding protocols, discuss factors that affect feeding tolerance in these children, and also we're going to be reviewing some of the 2017 Pediatric Critical Care Nutrition Guidelines that were published in July of this year. I wanted to start out by taking a little bit of a closer look at pediatric malnutrition in the hospitalized child. So this complex-looking algorithm summarizes the definition of pediatric malnutrition in hospitalized children as described by the Meta et al. 2000 paper defining pediatric malnutrition, a paradigm shift toward etiology-related definitions. And this kind of redefined the way we look at pediatric malnutrition. So if you look at the very top, you can see the different categories there: anthropometry, etiology and chronicity, the mechanism of malnutrition, imbalance of nutrients, and then finally, most importantly, outcomes. So in terms of anthropometry, the parameters that we're looking at, of course, are weight, height, or length, tricep skin fold, mid-upper arm circumference, Z-scores, reference charts, the CDC reference charts and the WHO reference charts. And then when you move into etiology and chronicity, if you look at non-illness related nutrition, this could be behavioral, socioeconomic, or environmental, and it typically means starvation if you move to the right of the screen. And starvation really just means decreased intake to the point where the child is malnourished, or the child can be malnourished due to an illness or illness-related malnutrition. Acute is defined as less than 3 months, chronic greater than or equal to 3 months, and then plus or minus inflammation. And illness-related could be also starvation as a mechanism, meaning decreased intake, depending on what that child's illness is. They may have a loss of appetite to the point that they become malnourished. It could also be related to malabsorption, nutrient loss, hypermetabolism, and or an altered utilization of nutrients. And these types of mechanisms may increase nutrient requirement, which may be one of the reasons that malnutrition is happening in a child with these types of conditions. So all this leads to malnutrition where intake is less than requirements. There might be an energy protein imbalance, which could also be paired with micronutrient deficiencies. So what does all this mean? Well, what this means is there's evidence-based outcomes that are related to pediatric malnutrition. And these negative outcomes can include loss of lean body mass, muscle weakness, developmental or intellectual delay, infections, immune dysfunction, delayed wound healing, and or prolonged hospital stay. So as you can see, if you look at this kind of whole algorithm together, what it really means here is that whether malnutrition is caused by an illness or not, and what the mechanism is, it leads to poor outcomes. Now this chart really just shows you malnutrition at the far right, whether there's no risk, a mild risk, a moderate risk, or severe risk, and how that correlates with Z-scores, with growth percentiles, and the Waterlow criteria. So Z-scores kind of came back into popularity and are used much more often. They are really the gold standard in terms of looking at the malnutrition definition. And this was really defined in that 2013 paper. So a Z-score of 0 all the way to -3, you can see how that correlates with malnutrition. This slide shows the mortality risk that is related to malnutrition. So you can see the Z-scores on the x-axis there, and then the odds ratio on the y-axis. So odds ratios, of course, are used to compare odds of the occurrence of the outcome of interest, in this case it's mortality, given the exposure to the variable of interest, i.e. malnutrition. So an odds ratio of 1 means the exposure doesn't affect the odds. An odds ratio of greater than 1 means the exposure is associated with higher odds of the outcome. So you can see that as you move to the right on that x-axis and you're getting more and more malnourished, you can see how that odds ratio just shoots up. Whereas when you get down to a -3 or less than -3 Z-score, the odds ratio goes up to almost 10. So you can see that mortality risk is related to malnutrition. This prospective cohort study by D'Souza Menezes, and this demonstrates that malnutrition is an independent predictor of clinical outcome in critically ill children. So the objective of this study was to determine the nutritional status and assess the effect of malnutrition on outcome in patients in the pediatric ICU. And the methods were, this was a prospective cohort study, about 385 children were assessed. And the outcome variables that were looked at were 30-day mortality, length of stay in the pediatric ICU, and length of mechanical ventilation. And patients with a Z-score of less than -2 of anthropometric indices were considered malnourished in this study. And the results of this study are that just over 45% of the cohort were malnourished on admission. And malnutrition was associated with a greater length of mechanical ventilation and a longer length of stay in the ICU. In this particular study, it was not correlated with mortality on univariate analysis. But we do know that nutrition delivery in the pediatric ICU is often insufficient. There is a great deal of evidence that shows us this. So a review here done by Ursula Kyle and colleagues at Texas Children's Hospital found that nutrition delivery in the pediatric ICU in this particular study was deficient. This was a retrospective chart review that included 240 PICU patients admitted for greater than 48 hours, and then all energy and protein intake was documented for the first 8 days of that PICU stay. And the investigators found that during that 8 days, only 40% of protein requirements were met, and energy intake was a little bit better, but not quite there at about 76% of basal metabolic estimate. So delivery of energy and protein were inadequate on 60% and 85% of patient days, respectively. And it really shows a high prevalence of critically ill children who are not meeting their recommended levels of protein and energy. And Neela Shmeta and his team at Boston Children's conducted an international prospective cohort study of children requiring mechanical ventilation longer than 48 hours in the pediatric ICU. And nutritional practices were then recorded during the PICU stay for a maximum of 10 days. And patients were then followed for up to 60 days or until hospital discharge. And this study found a high prevalence of malnutrition on admission, a striking inability to deliver the prescribed energy and protein intake, and also a higher likelihood of mortality in malnourished children. Delayed initiation of enteral feeds and under-delivery are also shown to be contributors to malnutrition in critically ill children, and GI intolerance has also been shown to contribute to malnutrition in the pediatric ICU. Impaired nutrition status in hospitalized patients has also been associated with a laundry list of poor outcomes, including poor wound healing, higher infection rates, longer length of stay, increased healthcare costs, and a higher frequency of readmission. So I think we're starting to get the picture here that nutrition is really critical in pediatric ICU patients. The goals of nutrition therapy in the pediatric ICU are really to prevent malnutrition. We know that malnutrition is associated with negative outcomes, to maintain lean body mass, maintain muscle function, prevent both under and overfeeding, prevent micronutrient deficiencies, and of course, increase positive outcomes. So how do we do this? Well, the newly published Pediatric Critical Care Nutrition Guidelines offer some direction in terms of avoidance of malnutrition and other poor outcomes related to nutrition delivery. So the original Pediatric Critical Care Guidelines were published in JPEN in 2009. The current guidelines are more comprehensive and robust and include more evidence to support each guideline. And this is a publication that represents a collaboration between two organizations, the American Society for Parenteral and Enteral Nutrition and the Society of Critical Care Medicine, to describe best practices in nutrition therapy in this population of children. So first of all, just want to talk a little bit about the guidelines. So if we're looking at management of nutrition risk and we're looking at nutrition status, one of the guidelines on nutrition status, 1A, recommends that patients in the pediatric ICU undergo a detailed nutrition assessment within 48 hours of admission, and that the nutrition status be re-evaluated at least once a week while that child is hospitalized. Because of course, patients that are hospitalized are at risk of nutrition deterioration during that stay. And identification of nutrition risk, the guidelines recommend that weight and height or length be measured upon admission to the pediatric ICU, and that Z-scores for BMI for age or weight for age be used to screen for patients at extremes of these values. And of course, in children less than 36 months, head circumference should be documented as well. And in terms of grade, you see the quality of evidence very low, and grade recommendation. Grade criteria is grading of recommendations, assessment, development, and evaluation. That's what that stands for. And really what this is based on is the quality of the study design and execution. So in terms of quality of evidence, if it's not a randomized controlled trial, that certainly is going to affect what is deemed the quality of the evidence. But then this grade recommendation looks at the quality of the study design and the execution to make a recommendation there. In terms of how to estimate energy, of course, as you might expect, indirect calorimetry should be used to determine energy requirements and guide the prescription of the daily energy goal. This is not always feasible. In fact, often indirect calorimetry is not feasible. So in lieu of doing an indirect calorimetry, this team suggests the Schofield or the WHO equations without the addition of stress factors. I think we all know that the Harris-Benedict equations and the RDAs shouldn't be used for critically ill children, but that is stated clearly within the guidelines. And in terms of how much energy that child needs to be getting based on what they're prescribed, this team suggests achieving at least 2/3 of the prescribed daily energy requirement by the end of the first week in the pediatric ICU. And of course, they are also suggesting attentiveness to individualized energy requirements, timely initiation and attainment of those targets, and energy balance to prevent unintended caloric deficit. On this slide, I just have listed the actual equations, the WHO and Schofield equations. I wanted to make sure that I provided them here because those are the equations that are recommended in lieu of indirect calorimetry by the guidelines. I wanted to show this because it shows kind of what equations are most popularly used in the pediatric ICU. This is a snip from Nilesh Mehta et al., the International Prospective Cohort Study, which surveyed nutritional practices in 31 PICUs in 8 countries. And this shows which equations were used by the nutrition team by prevalence. So most of most of the PICU dietitians and nutrition teams were using WHO, about 26%. Next was the Schofield equations with no stress factor, about 15%. Schofield with a stress factor, about 12%. And then some other kind of miscellaneous equations that were used, the Talbot's tables. Indirect calorimetry was low at 0.8%. Harris-Benedict, White, the White equation is a PICU specific equation that was published in 2000, and then others 4.5%. So it just kind of shows the popularity of different equations within this study. In terms of feeding the critically ill patient, there are many documented benefits to using the GI tract when that is feasible. And it's also recommended by the guidelines that enteral nutrition be the first choice. So some of the benefits of using the GI tract that are documented: maintenance of the GI barrier function, which can help prevent bacterial translocation and in turn decrease the risk of sepsis, a multi-system organ failure, improved nitrogen retention, enhanced wound healing, improved immune response, and lower morbidity, and of course, decreased length of stay, which leads to decreased costs. Early feeding has also been shown to support intestinal structure and function. So it's been shown to maintain gut barrier function, as I mentioned on the previous slide. It's been shown to increase secretion of mucus, and mucus-producing membranes line specific passages in the body, like respiratory and digestive tracts, for protection and support. Also increased bile and immunoglobulin A, which is an antibody that plays a critical role in immune function of mucous membranes. It's been shown to maintain peristalsis and blood flow to the GI tract, which can prevent atrophy. It's been shown to attenuate oxidative stress and inflammation, support the gut-associated lymphoid tissue that lies throughout the intestine. And of course, this is an immune support system. And also shown to improve glucose absorption. So obviously, if it's possible to use the GI tract, then use it. This study, entitled Gut Mucosal Atrophy After a Short Enteral Fasting Period in Critically Ill Patients, I wanted to show because I felt that this was interesting. This is not a pediatric study. This was looking at adults. The purpose of this study was to evaluate the presence of gut mucosal atrophy and changes in mucosal permeability in critically ill patients after a very short fasting period. So this was 15 critically ill adult patients, and they underwent a period of enteral fasting for at least 4 days. The mean actually was almost 8 days, but for at least 4 days. And you can't really imagine a child in the pediatric ICU not being fed for that amount of time. But it really is only a few days until atrophy starts to take place. And 28 healthy volunteers served as controls for duodenal biopsy and lactulose mannitol tests. And the investigators found that gut mucosal atrophy, and they described gut mucosal atrophy as a decrease in villus height and crypt depth in the patients that were fasted, the critically ill patients, compared with the controls. So what these authors concluded was that a relatively short period of enteral fasting was associated with significant duodenal mucosal atrophy and abnormal gut permeability in critically ill patients. So it is important to feed early. And what can help us feed early? Well, one of the evidence-based practices in terms of making sure that feeds are started early and are advanced is the use of feeding algorithms. So some of the barriers in the literature to reaching full feeds can include feeding intolerance and also an absence of a uniform definition of intolerance, interruption of feeds due to procedures, and fluid restriction. And algorithms have been shown in the literature to help optimize nutrient delivery and to kind of help get past some of these barriers. So the group at Boston Children's Hospital published a study in 2014 on the implementation of an enteral nutrition algorithm in their pediatric ICU. And they found significantly improved enteral nutrition delivery and decreased reliance on parenteral nutrition when they used this algorithm. And they also found that energy intake goal was reached earlier in a higher proportion of patients. And this is a chart from that study. I've kind of outlined the top 3 rows from this chart in terms of the variables. So essentially, they had 80 patients that were eligible for the study, and they were compared to a cohort of 80 patients in the pre-implementation audit. So pre-implementation of the algorithm and then post-implementation of the algorithm. So you can see the different time frames there. 2008 is pre-implementation, 2011 is post, and 80 patients in each cohort. So if you look at the first row, you'll see the variable there is days from PICU admission to starting enteral nutrition. And it's the same for both cohorts, 1 day on average. But then if you look at the second row, you'll see that variable, energy goal reached during PICU course, and it's a percentage there. 49% in the pre-implementation cohort, and 79% when the feeding algorithm was implemented. So there's a big difference there in terms of reaching energy goal. And then the third variable, median time to reach energy intake goal in days, 4 days versus 1 day post-implementation. So reached feeding goal much sooner after that algorithm was implemented. And what do the guidelines say about feeding protocols? They, of course, suggest the use of an algorithmic approach to advance enteral nutrition in the pediatric ICU. They feel that the evidence supports an algorithm including bedside support to guide the detection and management of enteral nutrition intolerance and the optimal rate of increase in enteral nutrition delivery. So not surprising that they suggest the use of an algorithmic approach for feeding in the pediatric ICU. In terms of administering enteral nutrition in the ICU, in terms of the feasibility, the Guidelines Committee recommends enteral nutrition as the preferred mode of delivery. Observational studies support the feasibility of enteral nutrition, which can be safely delivered to these children with medical and surgical diagnoses, to those receiving vasoactive medications, and they also suggest that interruptions be minimized. And one of the guidelines here that you'll see the benefit of enteral nutrition, they suggest early initiation within 24 to 48 hours and achievement of up to 2/3 of the nutrient goal in the first week, which they stated also in an earlier guideline, as that has been associated with improved clinical outcomes. In terms of the route, the gastric route is suggested as the preferred site. The post-pyloric or small intestinal route can be used in patients that don't tolerate gastric feedings or those that are at high risk for aspiration. And existing data aren't sufficient to make recommendations about continuous versus intermittent gastric feeding. They suggest that enteral nutrition be initiated in all critically ill children unless it is contraindicated. And again, early enteral within the first 24 to 48 hours. And they suggest EN guidelines and stepwise algorithms, once again, that include criteria for eligibility of enteral support, timing of initiation, and the rate of increase, as well as a guide to detecting and managing intolerance. This will really help you get past those barriers that are well documented in the literature. And in terms of initiating parenteral nutrition, they don't recommend the initiation of parenteral within 24 hours of the pediatric ICU admission. In terms of the role of parenteral nutrition as a supplement, they suggest an advancement of nutrient delivery via the enteral route and delaying parenteral nutrition, at least for that first week. Their supplemental parenteral nutrition should be delayed until 1 week after admission for patients with a normal baseline nutrition state and low risk for deterioration of nutrition status. And they suggest parenteral supplementation for those who aren't able to receive any enteral during the first week. And for patients who are severely malnourished or at risk of nutrition deterioration, it may be supplemented in the first week if they're not able to advance past very low volumes of enteral. And like the 2009 guidelines, this committee does not recommend the use of immunonutrition in critically ill children. Kind of the main barriers that are found in the literature to achieving nutrition goals in the pediatric ICU are fluid restriction, interruption of feeds due to procedures, and feeding intolerance. In terms of the feeding intolerance symptoms, typically you're going to see diarrhea and upper GI intolerance or delayed gastric emptying, but a higher percentage of prescribed enteral nutrition is associated with lower mortality and a decreased number of infectious complications. And again, feeding algorithms can help get past some of these barriers. And you can see some of the barriers here. So this was a study that was published by Dr. Mehta at Boston Children's and his team in 2010. And the objective of this study was to describe nutrient intake in critically ill children and then identify risk factors associated with avoidable interruptions in enteral nutrition. So if you can see here the different challenges that you'll see, including feeding intolerance, extubation, intubation, feeding tube issues, et cetera. And they have those divided into what they deemed avoidable interruptions versus unavoidable interruptions. So you can see here feeding intolerance. Those instances, 48% were deemed by these authors as avoidable instances of feeding intolerance. Extubation and intubation, 81% of those instances were seen as avoidable. So you can see here a lot of these barriers and these challenges to feeding in the pediatric ICU, many of them can be avoidable. This is a study that was done by Michaela et al. Looking at early enteral nutrition, and this team found that early enteral nutrition is associated with lower mortality in critically ill children. So the aim of this study was to examine the association of early enteral nutrition, and they described early enteral as 25% of the goal calories over the first 48 hours of admission with mortality and morbidity in critically ill children. So this was a multi-center retrospective study of patients in 12 pediatric ICUs. The patients ranged in age from 1 month to 18 years with a length of stay of greater than or equal to 96 hours. There were over 5,000 patients in this cohort with a median age of 2.4 years. And early enteral nutrition was achieved by about 27% of the patients. And those receiving early enteral nutrition were less likely to die than those who did not. And the conclusion of these authors was that early enteral nutrition was strongly associated with lower mortality in patients with a length of stay greater than or equal to 96 hours. Now, we talked a little bit about achieving nutrition goals, both energy and protein goals, and what the guidelines say about those. So what are the protein requirements in critically ill children? We know that they're higher than in healthy children. You can see here, these are the Aspen recommendations that were published in the 2009 critical care guidelines. You can see here that for 0 to 2 years of age, 2 to 3 grams per kilogram per day, 1.5 to 2 grams per kilogram per day for those 2 to 13 years, and 1.5 grams per kilogram per day for older children 13 to 18 years. And this is the amount of protein that's been shown to support resistance to infection, replenish pre-existing or injury-driven depletion, maintain muscle mass, and support losses of protein. Now, what do the new guidelines say about protein? Well, it's very similar, but there's one small difference. So they recommend a minimum protein intake of 1.5 grams per kilogram per day, much like the previously published guidelines. Protein intake higher than this threshold has been shown to prevent cumulative negative protein balance. However, they do not recommend a maximum amount of protein. The statement here is that in critically ill infants and young children, the optimal protein intake may be much higher than this minimum threshold. So the minimum is the same, but they don't have a recommended maximum because they don't really know what the optimal amount of protein is and really don't want to put a cap on that in terms of what the evidence shows. They also suggest the provision of protein early in the course of critical illness, and a delivery of a higher proportion of the protein bowl has been associated with positive clinical outcomes. I did want to go into a little bit more in depth in this 2012 meta study, which I mentioned very briefly at the beginning of this talk. This study was published in 2012 titled Nutritional Practices and Their Relationship to Clinical Outcomes in Critically Ill Children. And this was an international prospective cohort study of children requiring mechanical ventilation greater than 48 hours in the PICU. And they recorded nutritional practices during the PICU stay for a maximum of 10 days. So there were 31 PICUs in academic hospitals in 8 countries that participated in this study. The total number of patients was 500 with a mean age of 4.5 years. And these were the children that were enrolled and included in the analysis. So what was found in this study? Greater than 30% of patients had severe malnutrition on admission. We know that malnutrition is much more prevalent than we want it to be in critically ill patients, and this supports that. Enteral nutrition was interrupted on average for at least 2 days in over 70% of patients. And the mean percentage of daily nutritional intake compared to prescribed goals was 38% for energy and 43% for protein. So those goals were not even close to being met in terms of energy and protein, in terms of the children's needs. And a higher percentage of goal energy intake via the enteral route was associated with a lower 60-day mortality. Mortality was also higher in patients who received parenteral nutrition. And patients that were admitted to units that utilized a feeding protocol had a lower prevalence of acquired infection. So as you can see, some of the evidence that we see here really very closely is associated with what the guidelines recommend now. So this study demonstrated that protein is underfed in the pediatric ICU. And in this particular study, protein did not meet 100% of prescribed goals even after 10 days in the pediatric ICU. And inadequate protein has been associated with negative outcomes. And we're going to look a little bit more at that in the next few slides. We know that delivery of greater than 60% of prescribed protein is associated with lower odds of mortality in mechanically ventilated children. And preventing lean body mass depletion is one of the most important goals of nutrition therapy in the pediatric ICU. We also know that a higher percentage of goal energy intake is associated with lower 60-day mortality. Increase in energy intake from 33% to 66% of prescribed goals has been associated with lower mortality. And that we're going to take a little bit of a closer look at the protein study showing protein intake association with 60-day mortality on this slide. So this was a study that was done by Dr. Mehta and his group at Boston Children's. This was published in 2015. And the objectives of this study was to examine the association between protein intake and 60-day mortality in mechanically ventilated children. And this was a prospective multi-center cohort study. 59 PICUs from 15 countries participated. Mechanically ventilated children from 1 month to 18 years were included in the cohort, and these authors examined the association of protein adequacy and protein delivery with 60-day mortality. And the results of this study clearly showed that adequacy of enteral protein intake is significantly associated with 60-day mortality after the team adjusted for disease severity, PICU site, PICU days, and energy intake. So if you look at the bar graph there, you'll see that the black bar is protein adequacy that's less than 20%. The gray bar is protein adequacy between the range of 20 and 60%, and the white bar is protein delivery greater than 60%. So you can see on the x-axis, those groupings are divided into all patients, severity levels of 1 through 3, and severity level 4. And then you can see on the y-axis, 60-day mortality. And it's very clear if you look at the first grouping of bars at all patients, that mortality is much lower in those patients who received greater than 60% of prescribed protein needs. So this was a follow-up study that was done by Velasco et al., and this is the group, again, at Boston Children's Hospital. And for this study, they decided to take the cohort from the previous study, which included surgical and medical patients, and pull out the surgical patients and just examine that cohort. So the objectives of this study, and this one was published in earlier this year, 2017. So the objective of this study was to examine macronutrient delivery in surgical patients in the PICU. And again, this was a prospective international cohort study. There were just over 500 mechanically ventilated patients that participated in this study. And these patients had a 9-day median PICU stay. So what were some of the results? Enteral nutrition delivery was interrupted in almost 70% of patients for a median duration of 9 hours. So again, we talked earlier in the presentation about barriers and interruption of feeding due to procedures being one of the major barriers. Median enteral protein delivery was less than 15% of the prescribed goal and less than 60% in 2/3 of the cohort. And of course, that less than 60% number is in there because the previous study had linked that 60% number with mortality. So less than 15%, that's very dismal for this particular cohort. So needless to say, enteral protein delivery in this cohort was inadequate. And if you look at the chart on the right, you'll see that the x-axis is the day number in the surgical pediatric ICU, and then the y-axis is the percent of the prescription received. So you can see that the bottom two lines with the closed circle and the open circle, the closed circle is enteral protein delivery, the open circle is enteral energy delivery. And then above that, you'll see the triangles. The closed triangle is enteral and parenteral protein delivery. The open triangle is enteral and parenteral energy delivery. But you can see here that regardless of whether they're looking at protein or energy delivery, the delivery was woefully inadequate in this patient population. This chart shows improved survival, how improved survival is reported with optimal energy and protein intake. So I've kind of done a little bit of a summary here. The study is on the far left-hand side. We've actually reviewed all these studies except for the Wong study in this presentation. The number of children in the cohort, the mortality rate in this particular cohort, and then the outcome on the far right. So in the Mikhailov study showed that early enteral nutrition, patients receiving early enteral nutrition were less likely to die. The Wong study, which hasn't been reviewed in detail in this presentation, this was a study of 107 pediatric patients with ARDS. So these were very, very sick patients who had a high mortality rate. This was a retrospective chart review. And this study showed that mortality decreased to 35% when adequate energy was provided and decreased to 14% with adequate protein delivery. So again, you're seeing decreased mortality when adequate nutrition was provided. The meta studies we've reviewed, meta 2012, mortality decreased if energy intake was greater than 33%, and meta 2015, mortality decreased if protein intake was greater than 60%. Now, in terms of how to feed and how to avoid protein intolerance, it's important to look at the protein source and the hydrolysis of the protein. So certainly there are a lot of different categories of formulas. So you have your intact protein formulas on the far right, and those require more extensive digestion prior to absorption. Studies have also shown that intact casein has empties more slowly from the stomach than whey protein, so that can lead to slower gastric emptying if there is upper GI intolerance. And then if you go to the far left-hand side, you have kind of the amino acid category there. These formulas tend to have a higher osmolality, and there's less support for mucosa structure and function than a peptide-based or even an intact protein formula. Some kids that don't tolerate other types of formulas may need an amino acid formulation. And then in the middle, kind of between amino acid and intact protein, you have a peptide component. Whey protein peptide components have been shown to improve upper GI tolerance due to faster gastric emptying as compared to casein, have been shown to reduce diarrhea, improve nutritional parameters and outcomes specifically in patients who have prolonged inflammation in their GI tract, and support improvement in gut structure and function. This is a retrospective chart review done by Delusky et al. At Shriners Hospital for Children in Boston, and this looked at pediatric burn patients. And these were patients who required enteral tube feeding. The mean total burn surface area in this cohort was 45%. So this looked at two different types of formulas that were compared here and factors affecting nutrition support. So they looked at a whey-based peptide formula versus a casein-based intact protein formula and compared, first of all, days to achieve the feeding goal. And the whey-based peptide formula was 8.3 days versus 15.4 days in the casein-based intact protein formula. Incidence of diarrhea days, which they defined as greater than or equal to 3 loose stools per day. So you can see 0.067 in the whey-based peptide formula category versus 2.6 in the casein-based intact protein formula. And the percent of patients requiring formula held for high residuals was 56% in the whey-based formula versus 88% in the casein-based formula. This study showed that a whey-based peptide formula was better tolerated in this particular cohort than a casein-based formula for pediatric burn patients. Now, I mentioned on an earlier slide that whey protein has been shown to improve gastric emptying in children with delayed gastric emptying. And as I showed you on the Delusky slide, one slide prior, that whey-based formula has been associated with earlier achievement of feeding goals in pediatric burn patients. So you can see here this Petri dish, and this shows you a simulation of the acid digestion phase in the stomach under laboratory conditions. And on the left-hand side of the Petri dish, you see 100% whey protein peptide-based formula, and then you see on the right-hand side a casein-containing actually peptide-based formula. You can see that on the formula that is the 100% whey protein peptide-based formula, that when it hits the acidic environment of the stomach, or this Petri dish in this condition, it remains liquid. And that is one of the reasons that it empties faster from the stomach. Versus the casein-containing peptide-based formula, which you can see some curdling that's happening there, and that slows down gastric emptying, or can slow down gastric emptying. And the result is that whey protein, if it empties faster from the stomach, it can result in less vomiting, less reflux, less gagging and retching in patients that have delayed gastric emptying. Looking at some other enteral feeding considerations, we talked about protein, we talked about energy. Fermentation of prebiotic fiber is another tool that can be used to help in terms of feeding tolerance. So soluble fiber or prebiotics, the fermentation of prebiotic fiber produces short-chain fatty acids, and this has a variety of different outcomes. It can stimulate sodium chloride and water absorption in the colon, which can really help prevent diarrhea. Also, the short-chain fatty acid butyrate is the preferred colonic mucosal energy source, so that helps keep the GI tract healthy. And this fermentation process can also decrease the colonic pH, which makes the environment of the GI tract less favorable for pathogenic bacteria. And now we have another macronutrient to talk about briefly, fats and lipid metabolism. So we do know that lipid turnover is generally accelerated by critical illness, surgery, and trauma, and that critically ill children have a higher rate of fat oxidation. They are susceptible to essential fatty acid deficiency if they're administered a very low-fat or a fat-free diet. However, it's not very common that you would find an enteral formula for pediatrics that's very low in fat or fat-free, save for very specific conditions that require this type of formula. Medium-chain triglycerides are absorbed directly into the portal circulation and don't require bile salts for emulsification. So since these types of fats are more readily absorbed than long-chain fats, they may be helpful for those with malabsorption. And now to summarize some of the things that we talked about today, we do know from the evidence that there's a higher risk of malnutrition and associated complications in the pediatric ICU patient. We also know that early enteral nutrition has been shown to have advantages for nutritional status, immunity, and prevention of infection. And there are formulations aimed at improving tolerance and gut function. So to very, very briefly summarize the 2017 guidelines, they recommend the early enteral nutrition within 24 to 48 hours via the gastric route when possible. The recommendation is that supplementation or supplemental parenteral nutrition should be delayed until 1 week after PICU admission. The use of feeding algorithms should be used for advancement and monitoring. Delivery of 2/3 of the energy prescription should be given by the end of the first week in the pediatric ICU. Higher protein is necessary, and the early provision of protein has been shown to improve outcomes. And immunonutrition is not recommended in this population of children. Thank you very much. That concludes my presentation today.
Amy, thank you very much for an excellent presentation. We have had some questions coming in during the presentation, but feel free to ask more by typing them into the questions pane on the right side of your control panel. Here's a couple. The first one is, what is the most common type of GI intolerance in the PICU?
From the papers that I've read, delayed gastric emptying, I think is the most common. As I'm saying, this is, it's individualized by patient depending on their diagnosis. But from the papers that I've read, I think delayed gastric emptying is probably the most common, followed closely by diarrhea. Again, one of the issues is there's really not a very uniform definition of what intolerance is and all of that that's entailed in intolerance. I think everybody would agree that delayed gastric emptying and diarrhea are definitely two symptoms of intolerance, but I think those are the most common that I've seen in the literature.
Okay, thank you. What labs do you recommend for checking children with malnutrition?
What's interesting is that if you look at the pediatric malnutrition definition, really what they're much more focused on is nutrition-focused physical assessment for diagnosis of malnutrition. So I do know from different clinicians that I've spoken to, some are checking albumin or pre-albumin. I don't know how common that is in pediatric ICUs, but I do know that really the focus is more in terms of evidence-based diagnosis of pediatric malnutrition. The focus is much more going towards nutrition-focused physical assessment and those anthropometric markers of malnutrition that are shown in that 2013 paper by Mehta et al.
If a child is being fed parenterally, is there any benefit to trophic feedings?
Yes, absolutely. There certainly is evidence that trophic feeds can keep the enterocytes nourished and prevent atrophy in the GI tract. What's coming to mind to me, I've seen that defined as in a couple different ways. I'm thinking about the paper that was published in 2010 by Cook and Blinman from CHOP, titled Feeding the Pediatric Trauma Patient. I believe that group defined trophic feeds as 12% of nutritional needs. But a small amount of enteral nutrition certainly can help prevent some of the negative outcomes that you see with exclusively parenterally fed patients.
Do you have any recommendations on estimating protein needs in the critically ill obese child?
You know what, that is a great question, and what's interesting is critically ill obese patients are not included in the guidelines, and there's not a lot of evidence. I can't give you an evidence-based answer. I do know that some clinicians that I talk to use adjusted body weight. So they would use, obviously 1.5 grams per kilogram of adjusted body weight. That is not supported by any evidence, though, that I know of.
Different PICUs are meeting the elevated protein needs for pediatric patients different ways. So since standard pediatric formulas may be inadequate, what else can be used to help meet those needs? Adult formulas, modulars?
Yeah, there are a lot of different ways to meet, well, not a lot, a few different ways to meet protein needs in the pediatric ICU. So I think one of the first things to do to help meet both energy and protein needs is to use an algorithm. Use some sort of a feeding protocol for initiation and advancement of feeds to kind of get beyond some of those barriers. Some people use adult formulas. However, adult formulas are not formulated for children, and micronutrient the micronutrients are not designed for a pediatric population. And I know from looking at adult formulas versus pediatric formulas that there are certain micronutrients not only that are deficient in adult formulas for children, but also many that are in excess of what's deemed safe via the tolerable upper limit for children. There is a pediatric formula that is higher in protein, so you can use a higher protein formula. And then some people, of course, use modulars as well. So a few different ways to make sure that those protein needs are met.
Okay. Are there stress factors? Are stress factors ever used when you're using the WHO equation, the WHO equation?
No. The recommendation is to use the WHO equation without stress factors. Because even though protein needs are elevated in the child with that's critically ill, energy needs are not elevated. Energy needs typically tend to be less than a healthy child. So you've got to kind of strike that balance between making sure you're providing adequate energy, but energy needs are going to be lower than what a healthy child needs, but also making sure you meet that protein goal, which is higher than what a healthy child needs. But the recommendation at this point is that WHO or Schofield's equations be used without stress factors.
Okay. Do you recommend checking gastric residuals? And if so, what is the cutoff to determine intolerance?
That is another good question. So gastric residuals are checked by a lot of institutions, but what I've been hearing more and more lately is that in pediatrics, there's really not a lot of evidence to support the use of gastric residuals to show delayed gastric emptying. There is a paper that was published in 2010. Again, this was Dr. Mehta's group at Boston Children's that provides some recommendations. So there are some published recommendations in terms of gastric residuals. Some people suggest 50% after 1 hour, if 50% of the prior feed is left in the stomach, that is the cutoff. But like I said, there's not a lot of evidence that gastric residuals really correlate with delayed gastric emptying. And so I know that certain institutions are moving away from that and are using other methods that I've seen used are the acetaminophen absorption test.
Okay, well, thank you, Amy, very much. We're actually out of time, and thank you to the audience for being here today. On behalf of the Nestle Nutrition Institute, we hope you found this information helpful and valuable, and please enjoy the rest of your day.